Hi everybody, this is Mohamed A Yassin and I'm going to talk to you today about evaluation of hepatitis B reactivation among patients with chronic myeloid leukemia treated with tyrosine kinase inhibitors. As you know that hepatitis B reactivation in cancer is well-established complication due to chemotherapy-induced immunosuppression. The studies have reported hepatitis B reactivation associated with immunosuppressive medications such as rituximab, methotrexate, and high-dose steroids. Tyrosine kinase inhibitors are the standard of care in patients with chronic myeloid leukemia. The risk of hepatitis B reactivation in chronic myeloid leukemia has been reported in many studies, but to this date, there is no clear guidelines or recommendations regarding the screening and monitoring of hepatitis B virus in chronic myeloid leukemia. There are many or several associated unanswered questions, including but not limited to these questions. The first question is whether there is a need for screening of all patients who will receive tyrosine kinase inhibitor. This means in real world, when we got a patient with chronic myeloid leukemia, do we need to screen them for hepatitis B before starting tyrosine kinase inhibitors or no? And then if we talk about screening, what kind of a screening test we are going to use for those patients? Are we going to use hepatitis B surface antigen? Are we going to use hepatitis B core antibodies? Are we going to use hepatitis B virus DNA? Or are we going to use a hepatitis B panel? So there is a wide spectrum of a screening test which needs to be verified, and we need to talk about what screening test to be used. Then if we do screening and we found the patient is positive for hepatitis, so how we are going to monitor this patient and for how long we are going to monitor? Do we have to monitor the patient as much as a patient on tyrosine kinase inhibitor, or there is a period of maximum flare where we have to monitor the patient for a specific period like 1 or 2 years, and then we have to stop after that? We are going to illustrate that in our presentation. Then how long patients with chronic myeloid leukemia should be on hepatitis B virus prophylaxis? This is also an area of debate. Is it lifelong or is it during the specific period? Then another question, if you are going to use a hepatitis B virus prophylaxis, what are the best antiviral agent to be used for prophylaxis of hepatitis B virus patients who are on tyrosine kinase inhibitor? First, before going through all these questions and discussions, let's touch base on the definition of hepatitis B reactivation so that we have a baseline, and then we talk about further details. So how do we define the hepatitis B reactivation? There is a different definitions, and these definitions are variables in the literature. One of these definitions is hepatitis B reactivation is usually defined by changes in alanine transaminases, ALT levels, hepatitis B virus serological markers, or hepatitis B virus DNA. Another definition is hepatitis B reactivation can be considered in the following situations, where you have a 2 to 3-fold increase of ALT above the baseline, and hepatitis B surface antigen seroconversion, or detection of hepatitis B virus DNA in the blood in the absence of hepatitis B surface antigen, newly detected hepatitis B virus DNA, or a 10-fold rise in the hepatitis B virus DNA level compared with the baseline level before immunosuppression. Hepatitis B virus reactivation does not only occur in hepatitis B surface antigen positive cases, can also occur in hepatitis B surface antigen negative cases with a positive anti-hepatitis B core antibody and or anti-hepatitis B surface antibody. So this is a very important information where hematologist and clinician has to pay a special attention in the practice, because if hepatitis B surface antigen is negative, this is not the end of the story, and doesn't mean that the patient doesn't need prophylaxis, and it doesn't mean that reactivation cannot happen. So you should take in consideration this very important phrase that hepatitis B reactivation does not only occur in hepatitis B surface antigen positive cases. Patients with occult hepatitis B virus infection who have a detectable hepatitis B virus DNA, but hepatitis B surface antigen is negative, can also have a reactivation of hepatitis B. Hepatitis B virus reactivation in patients with occult hepatitis B virus infection is defined as either a seroconversion of hepatitis B surface antigen or an increase of at least 10-fold above the lower limit of detectable hepatitis B surface antigen and hepatitis B virus DNA if they were previously undetectable. For patients with occult hepatitis B virus infection who had a detectable hepatitis B virus DNA, a 1 log increase above the baseline would also regarded as hepatitis B virus reactivation. What does American gastroenterology guidelines tell us about the reactivation? The American gastroenterology guidelines tell us that the risk of hepatitis B virus reactivation in patients with hematological malignancy receiving chemotherapy is reported to be high. It's more than 10% of patients receiving a specific agents like rituximab, with a recommendation to start prophylaxis treatment for such patients, even if they have only hepatitis B core antibody positive or hepatitis B surface antigen negative. The risk in patients receiving tuber necrosis factor, a moderate high dose of steroid for 4 weeks, and a patient receiving tyrosine kinase inhibitors like imatinib, nilotinib, and dasatinib is reported to be moderate, 1 to 10%, with a recommendation for a prophylaxis against hepatitis B virus. But the strength of this recommendation is weak. What about the pathogenesis of hepatitis B virus reactivation secondary to the tyrosine kinase inhibitors? How does the pathogenesis happen? There are a probable mechanism of chemotherapy-induced hepatitis B virus reactivation are thought to involve a 2-stage, the immunosuppression stage and the immune restoration stage. In the immune suppression stage, there is a noticeable rise in the serum level of hepatitis B virus DNA and hepatitis B E antigen, probably due to suppression of the immune mechanism that helps to control hepatitis B virus replication. In the immune restoration stage, after the withdrawal of the immunosuppressive agent, rapid destruction of infected hepatocytes occur. What about imatinib and nilotinib particularly? How does the reactivation happens? How does they work at the level of microenvironment? How do they do with the T cells, the macrophages, and the progenitor stem cells? Studies have showed that imatinib can inhibit T cell activation and proliferation. Imatinib can also affect other immune cells in that it prevents the differentiation of progenitor stem cells to antigen-presenting cells and inhibits macrophage function. What about nilotinib? Nilotinib can inhibit the Src family kinase and LCK and T cell function and can suppress the CD8 and T lymphocyte proliferation and function. Always there is an argument and dilemma whether we have a hepatotoxicity or reactivation, and differentiation between the two terminology and the two phenomena is not always easy in clinical practice. Imatinib and other tyrosine kinase inhibitors are also associated with a hepatotoxicity. As a side effect, physicians may face a diagnostic challenge in a patient who is a chronic hepatitis B virus carrier and is receiving tyrosine kinase inhibitors. Differentiating hepatitis B virus reactivation from hepatotoxicity may not be easy. There has been a reported case in which a patient with a chronic myeloid leukemia who was a carrier of hepatitis B developed a severe hepatotoxicity and a liver failure, resulted in a fatal outcome. A liver biopsy of a patient showed a negative immune staining of hepatitis B markers, leading to the conclusion that it was not a hepatitis B virus reactivation, but rather a toxicity that caused the mortality. Other authors have also reported a biopsy proving significant hepatotoxicity due to imatinib. The exact mechanism of hepatotoxicity is unknown, but mitochondrial dysfunction and inhibition of glycolysis are possible mechanisms. Screening test. So what kind of screening test we have to use? Based on the data which we have gathered, it's advisable to screen all patients who are planned for tyrosine kinase treatment. Suitable screening tests include ALT, complete hepatitis B serology panel, which is including hepatitis B surface antigen, anti-hepatitis B surface antibody, and anti-hepatitis B core antibody, hepatitis B E antigen, anti-hepatitis B E antibody, and hepatitis B virus DNA. It is important to identify patients with possible previous hepatitis B virus infection, as evidenced by hepatitis B serological markers. For example, positive hepatitis B core antibody with a negative hepatitis B surface antigen with or without detectable hepatitis B surface antibody. Patients with only total hepatitis B core antibody positive most likely have resolved hepatitis B virus infection. However, other possibilities include false positive results, resolving acute infection, or low level of chronic infection. These patients are also at risk of reactivation. So before starting TKI, in our opinion, it is unacceptable to start treatment with tyrosine kinase inhibitor in chronic myeloid leukemia patients without assessment of hepatitis B surface antigen. Nevertheless, running all tests may not be feasible due to the cost and availability of the testing equipment. Therefore, if unavailable testing patients using only ALT and hepatitis B surface antigen, or even ALT alone, would be sufficient initially. What about the prophylaxis for hepatitis B surface antigen positive patients? For hepatitis B surface antigen positive patients, prophylaxis against hepatitis B virus reactivation should be started, as hepatitis B virus reactivation may happen at any time after the commencement of tyrosine kinase inhibitor. The duration of prophylaxis was mentioned only in the study by Wang et al. And was variable from 1 to 60 months. It is worth noting that the time to reactivation has a large range in the available studies, from 1 month to 69 months after starting tyrosine kinase inhibitors. However, the median time to reactivation is 9 to 10 months after tyrosine kinase commencement. And this is a very important information to know that the median time to reactivation is 9 to 10 months within this big range from 1 month to 69 months. What about the prophylaxis for hepatitis B surface antigen? Based on the currently available evidence, we recommend hepatitis B virus prophylaxis for patients with positive hepatitis B surface antigen receiving tyrosine kinase inhibitor. And prophylaxis be given from the start of TACI treatment and continued for at least 2 years after the commencement of tyrosine kinase inhibitors. If feasible, as the median time to reactivation is 9 to 10 months. What about the monitoring? How we are going to monitor our patients and for reactivation? If feasible, as a median time of reactivation is 9 to 10 months, the duration of prophylaxis is not well established, and our recommendation is based on the limited data available. If this is not feasible, it is advisable to monitor markers of reactivation, as mentioned above: ALT, hepatitis B surface antigen, hepatitis B virus DNA, whichever is available. For those with a possible resolved hepatitis B virus infection, positive hepatitis B core antibody, and negative hepatitis B surface antigen. We recommend monitoring for signs of hepatitis B reactivation during the treatment duration without prophylaxis. A reasonable schedule would be to start monitoring at a time 0, then 1, 3, 6, and 12 months in the first year of treatment. That's not the whole story, because there is areas of uncertainty, and most likely we are talking about 2 areas of uncertainty. The first area of uncertainty, firstly, it's unclear how long monitoring and prophylaxis should be given. This issue is clinically important, as CML patients receiving lifelong treatment with tyrosine kinase inhibitors, apart from a small group which can go for treatment-free remission. There are no available studies investigated the most cost-effective strategy of hepatitis B prophylaxis. The second uncertainty: there is no clear answer in the literature as to which antiviral should be used, and there are no studies specifically comparing the efficacy of different antiviral agents for hepatitis B reactivation prophylaxis in chronic myeloid leukemia patients receiving tyrosine kinase inhibitors. In guidelines for hepatitis B virus reactivation prophylaxis for hematological malignancy, entecavir and tenofovir are the recommended agent, with entecavir having the highest quality of evidence for its use. There is a considerable risk of hepatitis B reactivation in hepatitis B surface antigen positive patient with chronic myeloid leukemia treated with tyrosine kinase inhibitors. That's why, as a conclusion, we suggest that all patients with CML should have a baseline values of ALT, complete hepatitis B serology panel, as well as hepatitis B virus DNA if serology is positive, before starting tyrosine kinase treatment, and should be followed up with the repeated values of these 3 parameters as required. However, if cost and availability limit the use of this test, we strongly suggest following up with ALT and hepatitis B virus surface antigen levels before and after treatment with tyrosine kinase inhibitors. In patients with a risk of hepatitis B virus reactivation, positive hepatitis B surface antigen on screening, as well as those with a persistent hepatitis B core antibody. Prophylaxis with agents with a high resistant barriers, such as entecavir or tenofovir, can reduce the incidence of reactivation. Details remains unclear for the most effective antiviral agent, the duration and frequency of monitoring, as well as the duration of prophylaxis. In addition, the cost effectiveness of different approaches remains unknown, as the prophylactic treatment are expensive and not universally available. Further studies are required to provide appropriate evidence and to support such recommendation. These are some of the useful references you can go through. And at the end of this presentation, I would like to thank my colleague at the National Center for Cancer Care and Research for the support and the great work which we have done in chronic myeloid leukemia. And I would like to thank the International CML Foundation for their kind invitation. Thank you very much.